All right. Okay, everyone. I'm Dr. Mariuma, good to be here to talk to you. Good morning. So I will be discussing a collection of recent clinical trials in cardiorenal syndrome. So this is actually more of like a blaze through of a few small studies rather than in-depth attention to any one of them. And Before we begin, I just want to say a couple little pieces about cardiorenal syndrome itself. So cardiorenal syndrome is characterized by maladaptive activation of sodium-conserving pathways, despite the presence of hypervolemia. And we know that many patients are discharged with residual clinical hypervolemia, and there's a lot of data suggesting that that's associated with poorer outcomes. Treating cardiorenal syndrome is very challenging because we often run into issues of diuretic resistance. We always think of the heart hurting the kidneys, but we don't think of the kidneys hurting the heart. And the reality is that uremic toxins that we don't measure clinically are proven to be pretty injury-inducing to the myocardium. And there's also the fact that loop diuretics are a double-edged sword. You give them to get rid of fluid, but they also contribute to neurohormonal activation that's causing the sodium retention in the first place. So treating these patients is quite challenging. And it's also very difficult to study. The problem is these patients are very sick. The mortality rates are high. They're difficult to enroll. Creatinine changes in the context of diuresis, which I'll go over, are very nuanced and not a simple matter of AKI or not AKI. We don't have many great objective markers of volume status. There's plenty of work going in that direction, including POCUS, but we can't really say that we're great at that as a profession yet. And then no one really has a standard diuretic protocol. It's kind of different for everyone. And you'll see that the studies I go over are often small, underpowered. The methodology is very different study to study. And that's actually one of the points I want to make to kind of emphasize the challenge of studying this. So as a little, I'm not going to go over all of this in depth, but this is our UW diuretic protocol, which we've been using clinically. And it starts with a decision on the dose of a loop diuretic to start in someone who's clinically hypervolemic. And that is largely driven by the dose trial, which is one of the landmark trials that suggested that going for higher doses of a loop diuretic off the bat leads to faster decongestion, lower length of stay, and is better overall than trying to just do the same as what they were on at home. And that's something I think we all realize by now. The fun part of the kidney heart service, I would say, falls under step 3, because that's where we start really looking at things that are a little more avant-garde, maybe not as standardized. Metolazone or thiazides in general as an augmenting agent to loop diuretics do have some data through numerous small randomized controlled trials, and those are a little older, so I wasn't going to go over those. Hypertonic saline, there's also some small randomized controlled trials. And I know that Dr. Aurora has talked about that, so I'm going to be skipping that. And SGLT2 inhibitors have not been studied too well as a diuretic specifically, but we know that there's been an explosion of data in terms of its long-term benefits for people with CHF, proteinuria kidney disease, and we're going to have an excellent talk about that by Dr. Lamonte. So I'm going to not talk too much about that either. What I do want to focus on is first that we have a concern about going too fast, about, are we over diuresing or is the rate of diuresis too fast? And I would say, I think there are contexts where that's true, but there's also evidence that we might be overthinking that. And then I also want to talk a little bit about data regarding, or more recent data regarding spironolactone and acetazolamide. So the objectives are talking first about worrying less about creatinine changes in the rate of diuresis, diuretic choice, and options in terms of sequential nephron blockade and acetazolamide. So going into it, I'll start with some post hoc analyses that go over interpreting creatinine changes and rate of reversing volume overload. So in the world of cardiorenal syndrome, we've reversed, or rather we've shifted our paradigm from concern about cardiac index and low output being the driving force of renal dysfunction, and more focusing on venous congestion and central venous pressures, which have been shown to be correlated with lower GFR and higher mortality ultimately. We know that worsening renal function, which is defined as creatinine changes of 0.3 upward in the context of diuresis, can be associated with better outcomes, which, you know, is hard as nephrologists to stomach that. So there was a trial called the ADVOR trial that was initially done to look at tolvaptan versus placebo. I'm not going to go over that. I mean, in a nutshell, there are some benefits to tolvaptan in terms of dyspnea scores and urine output, but it's not clear that it's really correlated with lower length of stay and good heart outcomes. But they looked at people with HFrEF with clinical evidence of congestion, followed them for about 2.5 years. They excluded people with major valvular cardiomyopathies, mechanical cardiac support devices, or very advanced CKD. And excuse me, McCallum and others, they used the Everest cohort for a post-hoc analysis where they investigated for the development of stage 4 or 5 CKD and GFR declines of greater than 40%, depending on the rate of BNP or NT-proBNP reduction, the rate of reduction in a clinical congestion score that was used in the trial, and rate of hemoconcentration. So in this study, creatinine had been checked at discharge and was then checked monthly. In their analysis, they were only looking at creatinines that were checked post-discharge. And 3,500 patients were analyzed, and they stratified them by quartiles of reduction slopes of BNP. So the median GFR in discharge was 55. And what they found was there was no association between the discharge GFR and the rapidity of BNP decline. But the rapidity of the BNP decline was associated with the steeper decline of the in-hospital GFR. So what they showed was that if there was a greater rate of decrease in BNP or NT-proBNP or congestion score, you as well as greater rates of hemoconcentration. So you can see in these graphs that basically the more solid lines represent the most rapidly decongesting patients in terms of those changes. Those patients actually had the lowest rates of post-discharge incident stage 4 CKD. And then their secondary outcome was looking at a GFR decline of greater than 40%. And they found the same thing, that those who had the solid line, those who had the most rapid decongestion based on hemoconcentration or change in congestion score BNP, had the lowest rates of GFR declines of greater than 40% going forward years after the index hospitalization for which they were studied. So essentially what that would suggest is that really the rate of decongestion should not be a barrier, that we really ought to be decongesting these people very fast, because that actually seems to preserve their kidney function more in the long run. Some interesting things, though, when you use the randomization GFR, which is the GFR when they entered the hospital in the Everest trial, as a reference point rather than the discharge GFR when they were leaving the hospital, those relationships here were very much attenuated. And the only time there was statistical significance was when you were looking at the BNP reduction. But it still showed a signal towards greater rate of decongestion associated with lower rate of incident CKD. And, I think that one of the major limitations is that association could be confounded by the fact that those who inherently have better kidney function may just decongest faster. So that's in regards to rate of decongestion. The SOLVE trial, which is sort of solved, I'm not sure exactly how to pronounce that, from 1991. This trial compared, so this is an old trial, and one of the big trials that suggested the benefits of ACE inhibitors in HFrEF. We know that right now ACE inhibitors and ARBs are one of the mainstays of cardiorenal treatment, and they reduce cardiovascular events, they prevent maladaptive cardiac remodeling, and we know that GFR can acutely decrease due to relative dilation of the efferent arteriole. But the question of how much of a decrease do we tolerate has always been up for debate. I think we kind of stick with a 30%. But this was actually a recent post-hoc trial of the post-hoc analysis of the SOLVE trial. And in the trial, what they did was there were just over 6,000 patients analyzed, and they were looking at the change in GFR at the 2-week point. They followed up those patients for a maximum about 5 years. The median was about 3 years. And this graph is a little confusing because what they did was a bit unusual, but what they were saying here was that once the GFR in the SOLVE trial had declined past 20%, there seemed to be an increased risk of death. Now, that was true for both groups, but the hazard ratio for death was consistently lower in the enalapril group, which is why we sort of don't regard those changes as much, because at the end of the day, the same change happening to someone with placebo is still worse compared to the patient who got enalapril. But what they did is they made some assumptions where they said, okay, well, let's look at the people who had a 20% decline in GFR. And we can say, did the enalapril sort of benignly cause, well, we don't really know benignly, that's what they were looking at, but did the enalapril cause all those changes, or were all of those changes in GFR really just a reflection of the severity of their disease? So they did comparisons between the enalapril slope and the placebo slope at different points, depending on how much of the GFR decline you want to attribute to enalapril. So in the conservative strategy, what they're saying is, okay, we're gonna compare to placebo, and we're gonna assume that enalapril was the cause of every single one of those GFR declines. With the magnified, they're saying we're gonna compare to placebo, but we're gonna say the enalapril did not cause any GFR decline. We're comparing to the people in the placebo group who had the most GFR decline. I know that's a little confusing, but what they ultimately showed in these graphs, and these are graphs at the conservative method, where you're saying the enalapril was the cause of all GFR decline. So essentially you're looking at the data where you're putting the most potential blame on enalapril. And what they found was, when you look at the hazard ratio for all-cause mortality and heart failure hospitalization, so first, for all-cause mortality, once you got to about 10% GFR decline, the difference between an enalapril and placebo started to cross, the confidence ratio started to cross 1. So on one hand, that would suggest, okay, if we're blaming enalapril for all declines in GFR, once you've had a 10% decline in GFR, that's past that, maybe, we're not sure if that's still beneficial. But then when it came to heart failure hospitalization, up to 35% decline in GFR was still significantly associated with reduction in heart failure hospitalizations. So for the important point in the SOLVE trial, for all levels of enalapril related reduction in GFR, even if you assumed that all of them were induced by enalapril, the ACE inhibitor never increased mortality relative to placebo. It never crosses the placebo curve. But it does improve heart failure hospitalization rates, even as far as a 35% decline in GFR. And the authors of the study argued that, the fact that the statistical significance and the hazard ratio, as you went to greater reductions in GFR, became less significant, may not really be because, if an ACE inhibitor causes a greater than 10% decline, that's bad. We shouldn't keep it going. It may just be a signal of impaired autoregulation and vascular disease and the overall poorer prognosis of that patient. This study had limitations that were bound by the ones of the SOLVE trial, which is that the enalapril doses were sort of changed without any real attention, depending on what the clinician wanted to do. And of course, it's really an assumption. This whole method of doing things is just based on assumptions. This is actually a slide I gave to the fellows that to try to synthesize this information, where what does a rise in creatinine mean in the context of somebody with heart failure who's either getting very diuresed or getting an ACE inhibitor, and you're seeing a rise in the creatinine. And I think there's a few potential causes, and I even clinically I like to think of things this way. The first is that they may be having an appropriate reduction in GFR because they're having lower filling pressures, having lower cardiac output, so their GFR may be going down, but that's ultimately resulting in a lower CVP, which will improve renal perfusion and lead to long-term improvement in renal function and cardiac outcomes. And I think that can explain all the studies that show a mortality benefit in people with worsening renal function. You could also have an appropriate reduction in GFR from the hemodynamic effect of RAS inhibitors or SGLT2 inhibitors, which ultimately will result in lower neurohormonal activation and long-term improvement in cardiac outcomes and renal function. It could be ineffective diuresis. Sometimes the creatinine is going up. They're on a bunch of diuretics, but they're not really making a lot of urine. And that could be you're actually not diuresing them effectively. Their CVP is going up. They're getting more renal venous congestion, and their renal perfusion pressure is going down, and that can cause a drop in GFR. Too rapid a rate of diuresis, I would say. This is the one that I think is a little more controversial because we have some data to suggest that that's not a factor, or a faster rate of diuresis actually leads to longer term improved kidney outcomes. I would argue in people where you're not totally sure about their volume status, they're genuinely hypotensive, or there's something going on in their heart where preload is going to be a bigger issue, like they have a very acute right heart failure, severe valvular stenosis, or LV outflow tract obstruction, then I would argue that maybe you very much could be going too fast with your diuresis. Finally, some people do get genuine AKIs from RAS inhibitors or SGLT2 inhibitors that you have to consider in extreme cases of creatinine rise. And then finally, every other cause of AKI, which is why creatinine rises are so hard to interpret. But I really like putting it in these boxes because I think that this is a very useful way to interpret creatinine changes when you're diuresing a patient. So that was kind of the first topic. So second thing, and this this pains me considering my last grand rounds was all about torsemide being better than furosemide. So now I have to talk about the Transform-HF trial, which suggested that neither of them are better, but I'm also going to lightly criticize it. So this trial just came out. I had alluded to it last year. They compared torsemide and furosemide in inpatients with new or worsening HFrEF or HFpEF. They had a 30-month follow-up, and they were assessing mortality and hospitalizations. The patients were, it was a randomized multi-center trial, but it was non-blinded. They had about 2,900 participants. They were very inclusive in terms of kidney function, unless the patient was on dialysis or had a heart transplant or a VAD. They let anyone with any level of renal function be studied, and they were pretty liberal about what would happen with the diuretic dose. They left that up to the treating physicians. I don't have a very good slide to show the data, because this really was just presented at ASN in a slide. I couldn't find any kind of charts or an official release. But basically, what they found is that all-cause mortality, the hazard ratio was 1.02. The combination of all-cause mortality or any hospital rehospitalization was similar. Hazard ratio 0.92, and the confidence interval for all of this crossed 1. So they said no statistical difference in hospitalizations or mortality in patients who are given torsemide or furosemide. I do think there were some limitations. There was a high crossover rate of, I think, about 5 or 6% of the time from randomization to discharge. They tried to account for that by including an on-treatment analysis to compared to the intention to treat analysis, and finding the same results. But I think the biggest thing is that they powered this study to find a 20% reduction in all-cause mortality with torsemide. That's the kind of reduction we're seeing with SGLT2 inhibitors. I don't think anyone really expected that torsemide was going to be that impactful. So, they had a good end, but I feel if you're trying to look for a very nuanced difference, you may have needed more people. And then I'm shamelessly plugging in my slide from last year, where I meta-analyzed all the meta-analyses, where people compared torsemide to furosemide. And I would argue that some of these meta-analyses had more people overall, again, limited by very heterogeneous study methodology, but they did show potential benefit for heart failure hospitalizations. I don't think mortality really ever meant much except in one study, so I still think torsemide is not much more expensive. We know it has better pharmacokinetics. I think I can no longer, act all high and mighty and look down on someone who's using furosemide, but I still think that there are benefits to torsemide, and I'm glad we have Transform-HF. I do still think I'd be very interested if we had an even more well-powered study to see if there was a more subtle change in heart failure hospitalizations. So that leaves to and I realize I'm going to have to go kind of fast for this. So sequential nephron blockade strategies and options. So first, I'm going to talk a little bit about mineralocorticoid receptor antagonists. We know they're a key component for goal-directed medical therapy in HFrEF. They're associated with improved survival, reduced heart failure admissions. They often are withheld by cardiologists in patients with CKD4 or greater due to concern for hyperkalemia. But what I think is interesting to figure out is that, theoretically, blocking aldosterone should help with diuretic resistance. I mean, a big part of our thoughts of why patients have diuretic resistance is activation of the RAS axis. In the Athena heart failure trial in 2017, they randomized acute heart failure patients between spironolactone or adding spironolactone in usual care. And they found that there was no improvement in really any outcomes. But, they did look at people with GFR in the high 50s who were low risk on average, and were not requiring high doses of loop or thiazide diuretics as augmentation. So they weren't really looking at diuretic resistance. This diuresis CHF study was done in Belgium, actually by the same group that did ADVOR. They didn't achieve their recruitment target, but they just decided to kind of go for it anyway with 34 patients. And you know, there's similarities in their inclusion criteria for this and ADVOR, where they wanted to look at people who were dealing with diuretic resistance during decompensated heart failure. So patients who are at least on some, 40 milligrams of Lasix as a maintenance therapy as an outpatient. And then they used sodium, BUN creatinine ratio, and changes in creatinine as markers of diuretic resistance, which is a little, we could talk about whether those are good markers, but and then they excluded people who needed more than 80 milligrams of IV Lasix in a single dose. That's why I'm a little bit kind of iffy on it, because I feel like that's a better marker of diuretic resistance. And they gave everyone certain rules. They had to follow low sodium diet, fluid restriction, and then they checked labs in 24-hour urine for 3 days, randomizing patients to upfront spironolactone, meaning 25 milligrams daily and at discharge, or discharge spironolactone. So either starting it at discharge, or if they were on it as an outpatient, holding it for 3 days and then restarting it. And what they found was there was actually more natriuresis in terms of urine sodium over 24 hours in the upfront spironolactone group. But the total amount of urine output was not different, and there was no significant difference in the relative changes in BNP or worsening renal function or mortality or heart failure readmission. So really the only thing that changed was 24-hour sodium. But they also found that there wasn't really any major difference in terms of hyper or hypokalemia. So their argument was, this is something that can be used to enhance sodium removal from the body in someone that you're diuresing. And it doesn't seem to really cause a very high risk of hyperkalemia, especially in someone who's getting actively diuresed. Obviously, this study is very underpowered because they didn't achieve their recruitment target. And the other thing is spironolactone has a long duration of action. So if you hold it in someone and then watch what happens over 3 days, you're still getting some of the effect of spironolactone. So there are a lot of things I think that make this study hard to interpret. But it's an interesting kind of look at using spironolactone as something to enhance natriuresis. So the next thing this group did is the ADVOR trial, which I know we've talked about before. So I'm really going to just go over very briefly. So we know that acetazolamide works as a carbonic anhydrase inhibitor, so it leads to both bicarbonate urea and more natriuresis. And in the ADVOR trial, they similarly looked at patients admitted with decompensated heart failure who had been on maintenance furosemide as an outpatient. And again, they excluded anyone needing more than 80 milligrams of IV Lasix or equivalent. And they compared people who were getting 500 milligrams of IV acetazolamide for 2 days along with IV furosemide to those who were just getting IV furosemide twice a day. And in a nutshell, again, I'm kind of skipping through this because I know it had been gone over before. They seem to find a benefit in terms of that a congestion score and successful decongestion at discharge was improved in the group that received acetazolamide. And they looked at some secondary outcomes as well, in terms of just the sheer amount of urine output and natriuresis, and there was benefit in the acetazolamide group. What I really want to talk about are my concern about the limitations with ADVOR is that almost all the patients are white and Belgian, so there's always a question of external validity. They didn't investigate patients who are not on maintenance diuretics with a new diagnosis of heart failure. Their congestion scores, don't really account for newer techniques to assess volume. And really the biggest thing is that it didn't look at people with diuretic resistance. So they didn't really do an analysis of people who needed or subgroup analysis of those who needed escalating doses of loop diuretics. So, I think that the way I see it is that similar to the other trial they did, acetazolamide seems to provide natriuretic benefits, probably more than spironolactone, though it's not clear because the other one is kind of underpowered. But it's hard to really say how to use it in terms of diuretic resistance. And they weren't really looking much at or discussing the chloride sparing aspect, which is one of the things that I'd say me and Dr. Aurora are more interested in. So yeah, we can yeah.
Sorry. Thanks, Dr.
So the last trial, the slides are uploaded if you're interested, and anyone can ask me questions by email. But all right, any questions?
Yeah, a huge topic to cover. Thank you for going through so much content. Maybe just one question while Dr. Lamonte is getting herself ready to go. Feel free to unmute or put something in the chat. I'm curious, David, a lot, there's actually quite a bit more trial data for this topic than there are for other contexts, but you still have to kind of translate a lot of work that's been done on outpatients to the inpatient setting. And I wonder, do you think about that, the physiology of someone who's inpatient, acutely decompensated differently? And, you use that information like from the Everest trial about rapid decompensation. How do you think about that?
Yeah, so that's a great question. And I think a lot of what these trials that at least that I've discussed have done is include patients who are having an inpatient decompensated heart failure episode, making decisions about what they're going to do then, whether it's upfront acetazolamide or spironolactone or their diuretic choice, and then mostly observing what their longer term outcomes are. I think the problem with that is you're not accounting for any of the following outpatient management. You're not even really analyzing, are their diuretics getting adjusted? Are other medications being added or stopped? Those are, I think, a very big part of everything. And I think the hope was that if you just don't really look at it, then maybe it all kind of equalizes somehow. But I think you could then also argue that maybe some of the decisions that were made during their inpatient admission could influence the outpatient decisions that were to come. So I think that point is even more reason why this is such a challenging population to study, because you have this acute element and you have this chronic element, and finding a study that can adequately incorporate both is extremely challenging.
Certain amount of room for clinical judgment. Thank you, Dr. Mariuma. Much appreciated.